Welcome to the chapter of 22. We're going to talk about obesity. So for chapter 22, we want to understand obesity as a growing problem in the United States and also in the rest of the world. We're going to ask why, what is causing this so-called epidemic? We're going to ask, is it a private health crisis or is it a private health issue? And lastly, what kind of government responses are appropriate? So let's first talk about the widespread rise in obesity. First of all, we need to have a consistent measure of when is a person obese. So we have a very consistent measure called BMI. Probably a lot of you have heard about it. It is called body mass index. It is calculated by taking the weight of a person in kilograms, divide by the square of height in meters. So let's say if a person is a person's BMI is above 30, we consider this person as obese. And if a person's BMI is between 25 and 30, we consider this person as overweight. And so far in the United States, there are only less than 25% of the population, of the adult population, has a BMI under 25, which means that the majority of the adults in the United States are either overweight or obese. So body weights in the United States have been rising for at least in the past 150 years. The proportion of adult Americans who are obese has more than doubled between 1977 and 2006. So it has been increasing for the last 150 years, but the rapid increase are in the last couple of decades. It's not just a United States problems. It also has been rapidly increasing in every other developed country in the world. So let's look at the data. If we plot the proportion or percentage of population among adults that are overweight, obese, and extremely obese, we can see that these three lines, even though the overweight line has been flat, but the rest of the two lines have been quickly increasing, especially for the last several years. If you look at them by stratifying them and take a look into different education groups, you can see that even though with the people who have more education are having a lower average BMI, people of different education groups are all having an increasing body mass index for the last several decades. And if you plot this in different OECD countries, so OECD countries are a collection of countries, and most of them are Western countries and developed countries. You can see that a lot of these countries are experiencing an increase in obesity for the past several years. And the US has the highest increase, its highest overall rate. And if you compare US with Japan, you can tell how big the difference is. It's almost 10 times the obesity rate. So we know the trend, and now we want to understand what is causing this trend. So what explains increasing obesity? So these textbooks have five theories that explains increasing obesity. After this textbook was written, there are several new research studies that have come out, and we have some new theories and updated theories. So this is the increasing reasons are still under investigation. But here are five theories that the textbook has collected. The first one is genetics. Genetics plays the dominant role in your body weight and body type. If you look around your family, probably all of you have similar body type, regardless of diet and other factors. So while genetics may be very important. There cannot be the only reason for the rise in body weight, because over the last several decades, we don't see human genetics changing that much. So there must be some other things that have changed people's body weight. So the second theory is the food industry. So one popular theory for explaining obesity level is that fast food restaurants and agricultural corporations have pushed unhealthy, fattening, processing food and large serving sizes on these population who are not aware of that they are pushing it. So there is evidence that if a person lives close to fast food restaurants, it is correlated with an increase in body weight, and it's especially strong correlation among children. But even if the popularity of fast food restaurants have contributed to rising obesity since World War II, body weight has been increasing since at least the mid-19th century. So it's still it's a very powerful theory, but it's not the whole story. So the third theory is about food price. Since the World War II, improvements in technologies in agriculture and production and manufacturing have made food production substantially cheaper. And so it has driven down the prices of food. And you are studying economics. So the law of demand says that a decline in the price of a normal good will usually met with an increase in the quantity consumed. So price decreases, demand goes up, and people will respond to this price decrease as expected. So here is a plot of food prices. It has an uptick during the 1970s energy crisis. But if you look at the overall trend, you can see that even though with some seasonalities, with some shock, overall there's a declining trend in food prices. Okay, so food prices is not the entire story. And the fourth theory is changing lifestyles. So over the past several decades, people have more and more sedentary jobs. More and more people becomes white-collar jobs. They work in the office or work remotely at home in front of a computer. So there's less physical activities for these people. There is the technology of heating and AC, and people have found it more and more affordable. So most people will be able to have these technologies so that they don't burn the extra energy from their body to cope with changing temperatures. And the last thing is cars. The rising usage of cars has made people reduce their daily walking exercise in a lot of the developed areas. So that has also contributed to this changing lifestyles. Okay, and lastly, when we look in the economy in the broader sense, we also notice that there is increased labor force participation, especially by women. And this is associated with, let's say, less time at home. So people spend less time doing their housework, which they have to burn energy to do. And it's also associated with more time outside. So it's associated with more eating outside, which are also considered not good for someone's body weight. So all of these theories have their valid grounds, but let's not forget that some of these are good things. So obesity is sort of a side effect of a lot of the good things. For example, it's nice to have lower food prices. It's nice to have labor-saving technology innovations, to have these modern convenience ACs and cars, and to have more economic opportunities for women. Okay, so the next, we are gonna talk about the cost of obesity. When we think about costs, let's start from a personal level. If someone is obese, he has to pay or he has to suffer from the consequences of being obese. So for example, he or she will have higher healthcare costs. He or she will live shorter, a reduced life expectancy, and increased risk of chronic diseases such as heart disease, diabetes, and hypertension. He or she will not be able to have such physical mobilities and functions because of obesity. So there will be lower wages, will be social stigma. And so the next questions is, so all of these sounds like personal, but are these completely private, or some of them are actually public cost that has decreased the social welfare? So is it a public health crisis? From an economist perspective, the distinction between a public cost and a private cost is whether it is a public health crisis rather than a significant private problem. So is it a public health crisis? So under this welfare economics Robert, an outbreak of tuberculosis is a public health emergency, but a rise in the prevalence of back pain is not. So think about the case of tuberculosis. In this case, because it's contagious, so some of the drastic public actions, such as the quarantine, may be justified. Especially when a contagious disease is extremely deadly, then public action is extremely important. And it's justified to do that because one person's sickness might spread to other people. And so it's not private anymore. It's not just this person who gets sick is paying all the price, but the people who get the disease from that person will pay for his disease as well. Will pay for the consequence of his disease as well. But in another case with back pain, no government action is justified because unlike a tubercular patient in a crowded room, a person with back pain inflicts no cost on others. So for example, if this person ends up having a surgery or painkiller, this person will pay for it on his or her own. And it will not make someone else sick. It will not make someone else to pay for the contagion of the disease. Okay, so you might ask, how is obesity contagious? Or how can obesity be costly to someone else? And one obvious pathway is a pooled health insurance. So imagine several employees are in the same company. We call them Homer, Carl, and Lenny, and they paid the same premium for health insurance in this company. And this design is good to eliminate some adverse selection problem that we have talked about in some of our previous lectures. So suppose all of them have their own lifestyles, and it's okay that different people have their own lifestyles, right? And so imagine that today, Homer decides to eat an additional jelly donuts. And jelly donuts is probably not good for his health. So this one jelly donuts, let's say it end up increasing the medical bill for him for $1. Now, suppose this entire $1 is paid by him, then he should think about the utility gain from that jelly donuts and the cost he has to pay, not just the price for the donuts, but also the price of an increase in his medical bill. Okay, so that would be a situation when this person does when there is no pooled health insurance, right? But now there is a pooled health insurance, but pulling them together, The other people who did not eat the jelly donuts end up cross-subsidizing Homer's decision. So Homer now only pays 1 cent. And the other, let's say 99 people in the firm will pay the rest of the 99 cents. So the cost for he to eat a donut has decreased from $1 to 1 cent on top of the price for this donut. Okay. And so this creates a problem because when something's price has dropped, this something will be consumed more. So Homer is probably gonna think that, oh, so my consequence is $1, but I only pay 1 cent for this consequence. And so now if his price elasticity is more, if his price elasticity is elastic, if this changes his behavior, then he is gonna eat more donuts. So this is how we think about this problem, that we think whole health insurance have reduced the price of a private cost. It has inflicted public cost, and it has encouraged people to make bad decisions as a form of moral hazard. When we think about this moral hazard, it's something that is similar to when people have car insurance. They would know that even if they drive poorly, the car insurance will pay for it. So they start to drive not as safe as before, because now the price has been shared not just by the person who has insurance, but also the other people who have insurance. So there's one important hitch to this reasoning that bears on whether obesity epidemic is a public health crisis. So up to now, we have been thinking that the behavior of a person is completely under the person's control. So we have been assuming that body weight is completely under a person's control. But as anyone who has tried to do a diet or failed can attest that there are many influences in many biological factors that makes a person hard to control his or her own body weights. So let's say Homer cannot control his or her own body weights. Homer cannot control how much donuts he eats, regardless of the price. Then this creates another issue, that is, there is no moral hazard anymore because the price is inelastic. Even if the consequence, even if he bears less cost for the consequence of his action wouldn't change because he cannot control how much donut he eats. So the relevant question is, does health insurance actually make people fat? Does health insurance actually induce people to eat poorly? So here, according to RAND results, they compare people who are in different rate of the insurance market. So the more co-insurance rate, it means that the person has to pay more for the consequences of his or her diet behavior. And they simply find out that even if a person has or loses health insurance, it doesn't really change this person's eating behavior. If this person is a donut eater, he or she still eats donut with or without insurance. If he or she is a salad eater and is very healthy, having health insurance or without having wouldn't change how he or she maintains his own eating behavior. Okay, so maybe whole health insurance is not what makes people fat. And so then the next question is, what if obesity is contagious? So people start to think that maybe it's contagious, not in a virus way, but in a social way. So some researchers are concerned that obesity can spread, not through physical contact, but through links in a social network. So then if it spreads in this way, it would sort of qualify as a public health crisis after all, even though we think poor health insurance does not create social loss. So is obesity contagious? Researchers used data from a mass study of residents in Massachusetts who tested whether social networks spread obesity, and they find evidence of that there is contagion of obesity. So first, they find that subjects are more likely to become obese if the people they are tied to socially, let's say friends, relatives, and coworkers, become obese in the previous period. So further, obesity risk increases most dramatically when one person becomes obese in a mutually perceived friendship. So some people might critique and say, this is correlation, this is not causal evidence. So these observational studies, there is a question whether it is causality, right? So we have to find, we cannot really do an RCT and pair people to friends with who are less obese and more obese. So they have to find natural experiment. And so they find this natural experiment in the US Air Force Academy. So in the US Air Force, people don't choose their own dorm mates. They're randomly assigned to dorm mates. So they can be randomly assigned to someone who is physically better and who is poorly conditioned physically. And so they find out that if someone is assigned to a dorm with dorm mates who are poorly conditioned physically, his performance on the physical education assessments tend to suffer accordingly as well. And so this study suggests that associating socially with less fit peers does tend to degrade one's own fitness. It's a public health crisis, so governments are justified to propose some measures to reduce it. And here are some other justifications for public health intervention. So first point of view is from a welfarist point of view, because welfare economists assumes that individuals' choices should be respected by the government as long as they don't harm others. But if we relax this assumption, there can be additional justification. So for example, people might not have the information about certain foods. Some foods looks delicious. They don't look like they have a high calorie, but they might in fact does. So governments can ask restaurants and manufacturers to provide nutritional information so that the consumers can make better decisions based on the information they have. We have assumed that people make decisions on their own, and it's their freedom to do so, and they have to make the best decision for themselves. This usually is not the case for children. We have a lot of regulations surrounding children, and most parents are supporting it. So for example, children obesity is a problem. If a child is obese, then this child is likely to be obese in his or her adulthood as well. And so we don't think children, when they're young, they know which thing is healthy or unhealthy to eat. And we don't think children have the knowledge to know that what kind of eating would end up in what kind of consequences in their later life. So welfare economics believe that, okay, for children, there is justification for us to intervene to help reduce childhood obesity. Lastly, from a behavioral economics point of view, we believe that maybe some people, they don't have the best tools to make good decisions for themselves. So some people, they might gorge on cookies but regret it later. This is a kind of impatience and addiction, and it has to do with a person's time preferences. And if so, some economists believe that government will be justified to do some intervention. So for example, if a ban on unhealthy midnight snacks is actually in effect, probably we will help with the obesity. Will help people to reduce obesity, right? And people might, unless people will regret that they eat cookies in the midnight, which end up increasing their weights. But in a society where people have their own view of liberty, this kind of muscular government interventions will raise profound questions about liberty and the fundamental assumptions of welfare economics. Okay, so to conclude, the rapid rise of obesity and associated costs worldwide has inspired policy responses in many countries. In New York City voted to ban trans fat in restaurants. Japan started charging high premiums for citizens with waistlines above a certain maximum threshold. And Denmark instituted a tax on all products with saturated fat. So if there is no moral hazard, these laws do not actually affect total social welfare, but they do introduce a regressive tax. A regressive tax means poor people pay more tax, rich people pay less tax. And since obese people are the ones who tend to be lower socioeconomic status and lower income, so if we tax obesity, we might end up taxing the poor populations of our population. So governments are justified to do a lot of things, but we should scrutinize them. We should make sure that there is no unintended side effects, and we should examine to see if these things actually improves people's body weights. Okay.